Perfect. Hello, everyone. My name is Kim. I'm the partnership manager from AMBOSS. So while we are waiting for people to join in, we might quickly show you guys a brief. Oh no, the video is not attached. Okay. In that case, we'll just quickly wait for a little bit before we get started. For everyone who's here already, first of all, thanks so much for joining us, and feel free to use the chat, say hi. Maybe you can tell us what uni you're from, what year level you're in, and then we get started in a little bit. I'm quickly trying to find. Okay, so we have 23 people. I think we might just slowly get started, and whoever joins us can just come in a little bit. So yeah, again, thanks so much for joining us. My name is Kim. I am a doctor from Germany. I studied medicine in Germany and pretty much used AMBOSS throughout my entire time at uni, and also while I was working in orthopedic surgery in Germany for 2 years. And since 2 years, I'm working as a partnership manager for AMBOSS in Australia, and I'm really stoked to bring AMBOSS a little bit closer to students like you. And today I have Heather McNeil with me. Welcome to Heather. Maybe you can tell us a little bit about yourself, where you're from.
Yeah. So guys, I'm from the Gold Coast. For anyone that's like international, it's in Queensland, sunny Queensland in Australia. We have the best beaches in the world here. But yeah, I'm a third-year medical student at Griffith Uni. Really enjoying it in clinical years. And in a previous life, before I did medicine, I was an aerospace engineer. So that's why I'm really keen to teach you guys ECGs, because it's all just physics and I love physics.
That's why I think we have the perfect person today here to teach you guys. Thanks so much for doing this, Heather. Before we get started, I think we would like to run a few polls just to know who we have here tonight. So the first question would be what year of medical school you're in, and maybe you can quickly vote on the side, let us know. I think we'll be mainly first and second years, but sometimes we'll have a few third and fourth years who want to revise on certain topics, so that's good as well. And okay, cool. We have mainly second years. That's awesome. Thanks so much for that. The second question would be if you have used AMBOSS before, yes or no. That also helps us a little bit. Okay, strong yes. We'll see if there's a no, but it doesn't look like it. Awesome. Okay. And then the last question would be where is it? I always like to ask this one here. What's your biggest challenge when it comes to studying medicine? I think all of this is kind of true, but we'll see what you guys say. Too much information. Okay, and not enough guidance, yeah. No one says lack of time. That's very interesting. That was definitely one of my biggest problems. Okay, cool. Definitely too much information for a lot of you guys, and guidance seems to be a big issue as well. Perfect. Thanks so much for that. I think we'll leave it as with this, and now I would quickly like to share a few things about AMBOSS with you guys. I hope you can see my screen right now. Yeah, okay, perfect. So first of all, as most of you know, AMBOSS is a medical education platform. You've all used it before, so I think I don't need to go too much into detail. I think it's always interesting to hear that AMBOSS was initially created by 3 German doctors for the German students. And then after the German version was released, I think 2 years later, we had 95% of all the German medical students using AMBOSS. And then based on that success, they created the platform in English. And now we have almost 30% of Australian students using AMBOSS, which is really great to see. And the good thing, or the most important thing to know, is that we really have a huge team of international doctors on our editorial team who are writing the entire articles using international guidelines and making sure that everything that you look at is always correct, evidence-based, and up-to-date information. And therefore, you can really use AMBOSS as your all-in-one medical platform. It's a great exam preparation tool, but you can also use it when you're on the wards as a clinical decision support tool, because it allows you to access evidence-based information within seconds, which is really great. What I've used in the hospital pretty much every day is the mobile app. If you haven't downloaded that yet, then please do so. They are really, really great. And the best thing is that they work offline as well. So if you don't have reception in the hospital, you can still look at all the important content in the articles. And that is really, can be life-saving, and it's pretty good support for the wards. And just to show you a few features, especially if you're in your preclinical years, this was always one of my favorite features. So we have something called Smart Zoom that allows you to really look at a certain histo slide, pretty much zoom down to cellular level, and it shows you what exactly you're looking at. So this is pretty cool, and definitely helped me to understand a little bit better what I'm looking at. And then we also have some cool interactive anatomy quizzes in the platform where you can really apply knowledge in an interactive way to remember things a little bit easier. And then really important for everyone who's keen on Anki, we have this super cool Anki add-on where you can use AMBOSS and Anki combined. And we are going to run an Anki workshop on August 11th, so this week at 8 p.m. If you haven't signed up for that yet, you can do so via this QR code, and we also have the link on our AMBOSS Australia Facebook page. Then, as you guys all said, not enough guidance is a problem. We have created a study guide together with AMSA MedEd that you can also download for free. If you just Google AMBOSS AMSA MedEd study guide, you'll find that, and you can then download the PDF for free. And that really gives you a good overview of all the high yield topics that are relevant for the Australian curriculum. Has been created together with students from all universities to make sure that all the topics are covered. And if you then open up a certain specialty like cardiology, for example, it gives you all the relevant AMBOSS articles that you can read and study to this topic to make sure that you cover the entire content. So pretty cool, have a look into that. And then, when it comes to the upcoming tutoring sessions, we have 2 more sessions coming up in August, one on diabetes and complications and one on cardiac medications. So save the date for those ones. They are both at 7 p.m. AEST as well. And then last but not least, as I said, we have a Facebook group and we have some prize raffles that we will do there for each upcoming event. If you share this with your friends at your uni, then you can win a prize. And today we have 2 winners as well, and that's Rose Preet-Gurn and Amir Zabihi that won a 12-month AMBOSS code. I'll also message you on Facebook to make sure that we can set you up with your access. So if you haven't joined the group yet, please do so. And maybe next time you'll be a lucky prize winner as well. And now I would hand over to Heather to guide us through ECG.
Awesome.
Sorry, one more thing. Again, please feel free to use the chat. If you have any questions throughout, I'll monitor the chat and I'll make sure that that we cover them. Perfect. Sweet. Thanks, Heather.
All right, I am just going to share my screen and probably turn my camera off. And we'll pop that one up there. All righty. Cool. So that looks like it's coming through. At least I can see it on my computer. Just checking everyone can hear me and see those slides. Give me a yes or a smiley face in the chat if you can. You will find out that I love smiley faces, guys. So I'm going to be asking for lots of those in the chat as we move along. All right. You said that's coming through, Kim? Yep. Excellent. Cool. So guys, I'm going to be running you through an introduction to ECGs. And essentially what that means is we're going to be going through all the content that's up here on this screen. It's not going to cover every single ECG that you will see in the hospital. There are so many, we would be here for like 6 hours explaining all of them. But what it's going to go through is the really high yield ones and the ones that clinicians expect you to be able to identify. So to do that, we're going to wind it back to basics and cover what an electrocardiogram is, what an ECG is, and why you need to care about them. Even if you're not on gen med or cardio, you could be over on mental health, you still need to care about them. how the ECGs work, so going through the physics of them, or as most people like to think of it, the magic behind them, and then going through a step-by-step guide that's up on that AMBOSS website. And it's a guide that I have followed every single time one of the consultants has tried to pimp me out with a question on ECGs. If you follow this step-by-step guide, even if you don't know what's going on, you have no idea what the condition is, you can at least say it's normal or abnormal and where that abnormality is. And 9 times out of 10, the clinicians are going to be super impressed with you when they give you that danger squiggle and you can tell them what's going on. As we go through that, we're going to go through a couple of the key abnormal ECGs you need to know before you start your clinical years. And then at the end, we've got some AMBOSS questions. And I think we've got a few subscriptions up for grab. Is it, Kim?
Yes, we have 3 3-month codes up for grabs for everyone who's keen to stay for the quiz at the end. So yeah, we'll do that once you're finished.
Awesome. So that's pretty much our plan for tonight, guys and girls. So let's get cracking. So what is an ECG and why do you need to care about them? So this is pretty much taken from the AMBOSS website. Basically, they are a recording of the electrical activity of the heart. And we capture it using these little external electrodes. You probably have seen them before in some of your preclinical classes, or for the clinical guys that are here, those little sticky tabs that we put all over people's chests and arms and legs. They're your little electrodes. Those 10 electrodes we put on the body end up giving us this danger squiggle output. So lots of wiggly lines that we're going to learn to interpret tonight. Some of the reasons we use them is to detect things like your myocardial infarctions, different arrhythmias, even things like cardiac tamponade or pericarditis. They can even show us things or indicate suspicion of things like PE, so not even related to the heart, related to the lungs. And it's not just stuff heart related. I remember on neuro, I just came off my neuro block a couple of weeks ago. We had a guy come in with neurological signs and symptoms. We weren't actually we didn't think the way it presented, we didn't think it was because of atrial fibrillation, where you get some clots that might come out of the heart and get stuck in the brain and cause those signs and symptoms. But we had to rule it out. So we still did an ECG to rule out that the cause was atrial fibrillation. And we did a few other investigations and found it was something else. So it's not always just diagnosing things. It's often to rule out causes as well, rule out cardiac causes of conditions. We can also use them, if anyone's seen it, a cardiac stress test. So for anyone who might not be medicine, who maybe is allied health that's here tonight, you may end up running some cardiac stress tests, any of my physios or exercise students that are here, where we actually get people to run on a really steep treadmill and we try and induce some changes, looking for risks of the heart. And sometimes we don't even use it in the actual hospital itself. We might not be able to see anything on the ECG when they're in hospital. So we'll give them this thing called a Holter monitor and send them out into the big wide world for a day or two and get them to come back. And we collect like 24, 48 hours worth of ECG recording to see if we can capture the event that might be causing their signs and symptoms, which we couldn't actually see when they were an inpatient. So lots and lots and lots of uses of ECGs. So this is why you need to care about them. So how do they work? The physics or the magic, whichever you want to whichever you prefer, behind them. So if we do a quick recap, I'll just grab where's my squiggly thing? There it is. If we take a quick look at ECGs, as I've said, we're looking at the electrical activity of the heart. And basically where the magic starts is up here in that sinoatrial node. And it sends deep or action potentials, so depolarization, down these internodal pathways and also over to our left atrium here with our Bachmann's bundle, but down these pathways to our AV node. And then that signal continues down our bundle of his and our left and right bundle branches, and then loops around and depolarizes all of that ventricular myocardium. So in a nutshell, we have sort of a net vector of electrical activity that's going like this. And the heart itself is a 3D structure. It's not just 2D like in all of our textbooks. And that's why we have a lot of different electrodes or leads, because we want to look at it at a bunch of different ways. But to explain why we get squiggly up and squiggly down lines, I want you just to imagine it as a 2D structure to start with. So we'll just picture it like this down in this diagram, or this one up here. And let's just say I've put an electrode over here, right up near my right atrium. So this is my right arm electrode. It's a negative electrode. And down the bottom here, near the apex of my heart, we've got a positive electrode. And as I said, the net vector, when we look at how that electrical current tends to flow through our heart, is kind of traveling in that direction from the negative to that positive electrode. And what we find is if I draw it up over here, we've got negative, positive, negative, and positive. If that positive propagation or that action potential, which is that positive signal, is traveling towards our positive electrode, then what we get is a net upward deflection. So we get that sort of upward spike on our danger squiggle. So positive waves, so what we can see here and here, they're because that action potential or that depolarization is moving towards that positive electrode. Whereas if we have an action potential, say maybe going back this way, so it's now traveling towards the negative electrode. So that might be, once we get down to this apex, that signal's coming back that way. So it's now heading towards that negative electrode. If you have that positive action potential going towards a negative electrode, that's when we end up getting a negative wave or that negative deflection. So you'll see like here and here, we're getting that negative wave happening. Can I get a smiley face if that's making sense so far? Why some waves go up and some waves go down? Or just give me a yes in the chat, whatever floats your boat. I'll wait for a couple of yeses and smiley faces to come up, or say a no in the chat. We can go over it again.
And sometimes has a bit of a delay, so I'm pretty sure there will be some yeses coming through soon.
Good. Yep, I'm seeing some smiley faces. Fantastic. The last thing that you guys need to understand or get your head around, and this is really important for the T wave over here when we'll discuss that in a bit more detail as we get to our waves. But we need to understand what happens when we have repolarization, because obviously all these cells will depolarize so they can then contract, but we've also got to repolarize that cell. If we think about that cardiac action potential there that's hidden beneath my diagram, but we've got to repolarize them too so that we can then contract them again and depolarize them again. And what we find is that repolarization, so I'll write repol here, is a negative charge, whereas depolarization is sort of a positive charge. So that negative charge, if that negative charge heads towards the positive electrode, it will actually give us a negative wave. Whereas if that negative charge, that repolarization, is heading towards the negative electrode, so kind of like what we would see when this part is repolarizing, it's going to give us a positive wave. So basically, if you've got positive going towards positive or negative going towards negative, you're going to get a positive deflection overall. If you've got positive going towards negative or negative repolarization going towards a positive electrode, it's just like maths. Positive times a negative gives you a negative or an upside down wave. Hopefully that sums up why some waves are positive, why some waves are negative. Really important that you guys understand this, because even if you get an ECG that you have no idea what's going on, if you can see how it's varied from the normal, whether maybe you've got, say, a P wave that, if I draw that up, should look like this, but is now suddenly looking upside down, or maybe is looking really positive, you can actually have a guess of what might be going on. And that leads me to the last point about how these waves look, is it's one direction of charge, gives us positive and negative, but the reason we get some really big waves is it's also to do with how much electrical current is moving in that direction. So we can see when our atria depolarize, we get this little blip here called the P wave, and it's quite small. But when our ventricles, these really, really big chunky ventricles, they're nice and thick, they've got a lot of electrical current going through them, we get this really big positive deflection. So the bigger the electrical signal, the bigger a wave you're going to see. And that is literally 101 of physics that you need to know for your ECG. Really recommend the osmosis ECG video too. It's linked on the AMBOSS website. So if I go over to our AMBOSS ECG website here, so I've just typed ECG in. If I click on summary here, it's actually got it linked for us as well. So AMBOSS is really great like that. They do share really good, useful resources from other sites as well. So really recommend you guys check that out. Alrighty, let's jump back over to this PowerPoint. Cool. Actually, I'm going to jump back to the AMBOSS website because we're now sort of at the point where we're going to work our way through this website, and then I'm going to add little tidbits in on the PowerPoint itself. So we've covered basically everything that I've spoken about, or everything I've spoken about sort of summed up here, what an ECG is, and then we've gone through the physics of it. Now let's actually talk about how we set an ECG up. Because like I said, we can imagine the heart 2D, but it's a 3D structure. So we can't just sort of rely on this nice little 2D picture here and two electrodes, one lead, everything's shown. Doesn't work like that. You need to have a look at it from all different angles. And we do that by using a number of different electrodes and leads. We use 10 electrodes, so we put 4 on our limbs and 6 on our chest. And I love this diagram here. This is a really, really good diagram that AMBOSS has. So we've got 4 that go on our limbs, 1 on our right arm, 1 on our left arm, 1 on our right leg, and 1 on our left leg. This green one here, this right leg, kind of acts as a ground. For anyone that knows a little bit about electricity, you need to have a ground in order for current to flow. If we don't have that, the ECG doesn't work. But some variants you may see is sometimes they'll put this right and left electrode and they'll put it up on the mid-clavicular line or even just under the ribs. But this is the standard way we set it up. Then we've also got 6 chest electrodes. So we have V1 and V2 here. They sit either side of the sternum in the 4th intercostal space. V4 sits in the mid-clavicular line in the 5th intercostal space. And V5 and V6 are in sort of the 5th intercostal spaces, anterior axillary line and mid-axillary line. And V3, you kind of just whack on in between V2 and V4. There's not really a scientific place it goes. You just put it right smack bang in the middle. So this is really important to learn how to find those places and palpate for those intercostal spaces in the sternum when you start getting to clinical years. I will just note there are such things as V7, 8, and 9. And also right-sided leads. Little bonus question for anyone. Does anyone know when we would use right-sided leads rather than left-sided? Be super impressed if anyone knows a condition that we might need to use leads on the right side instead. See, I'll just give a moment because the chat's a bit laggy for me. Oh, does anyone know the name of a condition where the heart actually sits on the right side of the body? Yeah, nice. SN said dextrocardia. So has Michelle. Perfect. Yeah, so dextrocardia, you'd actually set it up this way. We also set it up this way too if we want to look at what's going on in the right ventricle in a little bit more detail. But for purposes of this session and for almost 90% of what you're going to do in the hospital, we generally just go with this setup. So these 10 electrodes then turn into 12 leads. So we end up with 6 precordial leads, and they capture the activity of the heart in a horizontal plane, and 6 limb leads, and they capture it in a vertical plane. And I'm going to jump back to my PowerPoint just because this is from that osmosis video that I linked. So the one that AMBOSS has linked on their website, really good video, just took a screenshot from that. So we can see we got right arm, left leg, right leg just acting as a ground. So we got those 6 limb leads, and they are lead 1, which goes from the right arm to the left arm. So we can see any depolarization or any electrical activity that's going from this right arm direction to this left arm is going to show us a positive wave because it's moving from the negative to the positive electrode. Anything going from the right arm down to our left leg is shown in lead 2 here, and that's going to give us a positive deflection as well. And that's why we tend to use this run strip down the bottom here. So we have this little strip down the bottom, which goes for full 10 seconds rather than these individual leads, which only show us about 5 seconds each. This one down the bottom generally is lead 2 because remember we find that sort of main axis that the electrical activity travels along is in line with lead 2 there. And then we have lead 3 as well. Now, you've also got these things called augmented leads. So this is your right augmented lead. So AVR runs off to the right arm. The AVL runs off to the left arm. And then AVF runs straight down towards like the feet or to the inferior or to that left leg. These have like a sort of imaginary virtual node in the middle there that is negative. And then each of these become positive again. So bonus question for you guys again, and this is you're gonna have to think about this one. What do you think the waves are going to look like in AVR if we're going from a negative electrode here up to a positive electrode in the right arm? What do you think those waves are going to look like? Will they be positive? Will they be negative? Will they look exactly the same as lead 2, different to lead 2? Giving you a little hint there. So a couple people saying positive. So think about when our heart's depolarizing, that electrical activity is going in this direction here. So if it's heading this way, it would be positive if it's heading towards a positive electrode down here, like what it's doing in lead 2. So it's going from the negative to the positive electrode. So that's why lead 2 looks like that stereotypical sort of QRS that you've got, that upright QRS. What you find though in AVR, because the negative lead is here and the positive lead is up on that right arm, it's almost the opposite direction to where our electrical current is flowing. So what we find is if you look here with AVR, everything's actually upside down. Oh, it's a little bit small. I'll put the link to that ECG in the chat in just a second, but everything's actually upside down. All the P, QRS, and T waves are upside down. That is a good thing. This is a sanity check you need to do with every ECG you get. Check that things are upright in lead 2 and upside down in AVR, because that tells us we've put the leads on correctly, or they probably are all put on correctly. If things are looking a little bit funky or the other way around, it means you might have got some right arms or left legs and left arms back to front. So that's our coronial plane or our limb leads. Our chest leads then go and cut this guy sort of in half like this, and look at the heart from this transverse plane. And these are really good at showing us what's going on in our ventricles. So these are your V1 to V6 leads over here. And what you find if you think about the heart anatomy, you've got sort of your right atrium over here, your left atrium against that back wall, and then on the anterior, you've got your right ventricle, and then over on the lateral wall, your left ventricle. So you can see how V1, V2, bit of V3 tend to show mostly that right ventricle, whereas your V5 and 6 are really showing that left ventricle. And V3 and 4 are sort of showing right down that septum there. So that's how we can actually work out what area of our heart things might be going wrong, because all of these leads kind of correlate to different areas or different surfaces on the heart. So your lateral leads, like I was saying, are those leads V5 and V6 looking right out laterally here. And also we've got lead 1 and AVL because they're pointing towards that lateral area. They're pointing out over on the left here. So we call them our lateral leads. They're looking at that left ventricle and that lateral wall. So that's another thing you can do if you get handed an ECG and you go, I have no idea what's going on, but things look pretty funky in these 4 leads. Something's up with that left ventricle or that lateral wall. Similarly, your inferior leads are going to be those leads that are pointing down. So lead 3, lead AVF, and lead 2. They're all pointing down towards that left leg electrode. They're looking at that inferior surface, this underneath surface of our heart. And then lastly, you have your anterior or your anterior septal lead. So that's the ones left over, that V1, 2, 3, and 4. So these ones here and the front, those anterior leads. And this is really important for when we get to STEMIs later in this talk, because these line up with a lot of our vessels as well. So those big main vessels supplying the heart. And when you get a block of them, you actually see changes in these different leads depending on where that block is. Alrighty, so the last thing I'm going to go over, if I jump back to AMBOSS here, and that table there is from AMBOSS that we just went through, really, really useful table. This one has gotten me out of so much trouble when I was first starting to learn ECGs and figure out STEMIs and where things were going wrong. Really useful table, that one. Really recommend you guys learn it. But the last thing we're going to do before we actually start working through all the different waves and the common abnormalities that we see is just have a quick chat about what each of these waves represent. Because like I said, there's a lot to learn on ECGs, and trying to learn it takes a while. A lot of the time it's pattern recognition and seeing things again and again. But if you know what a normal ECG looks like, so this picture here is a normal ECG. If you know what a normal one looks like, you can work your way through the ECG and go, hey, that P wave's looking pretty tall, or maybe that PR interval's looking pretty long. It's not as short as it should be. You can work out where the issue is in the heart. So if I jump back to my slide, probably for the last time, hopefully, maybe 1 or 2 more times I'll jump back, and then the rest is just going to come off the website, is we're just going to have a quick chat about what each part of this ECG, this normal ECG here, so I'm going to write normal up the top, how does it relate to each part of the heart? So if we go back to what I said before, we got that sinoatrial node or sinus node up the top here. This is where the magic starts. It sends a signal down these internodal pathways here, and this Bachmann's bundle over to our left atrium and our right atrium here, sends that signal down. Now that electrical activity is picked up by those electrodes, and it's represented here in our P wave. So this is our atrial depolarization. I'm just going to write AD here because I'll probably misspell depolarization knowing me. So that's our atrial depolarization there. That's what our P wave's showing. So if it starts looking really weird like this, or has a weird funky camel shape hump, you know something's up with our atria. The next part of this thing that we're going to look at as we go through our step-by-step guide is the PR interval. Now, this is what starts from the start of the P wave to the start of this Q wave here, this QRS complex. And the PR interval is your P wave plus this thing called your PR segment. Does anyone know what the PR segment represents? Throw another question out to the chat, because I like to get everyone involved when I'm teaching. So anyone know where the PR segment is in terms of our heart electrical activity? Which part of the heart does that sort of represent? Give you guys maybe like 10 seconds. I'll wait 10 seconds to see if anything comes through on my end.
I'll let you know.
Yep.
Bundle of his. Yep, bundle branches.
Yeah, very, very close. So the segment itself is sort of that AV node and a little bit of that bundle of his, but it's mostly in this AV node up here. So right before that bundle of his. Really good guess there, Dylan. I think some sources do also suggest it's part of the bundle of his too, but it's mostly that AV node. And the reason for that is this flat line means there's not really any electrical activity going one way or another. So it's sort of either nothing's happening or the electrical activity going one way and the opposite way are cancelling each other out. And what we find is at this AV node, the way the AV node or the way it's set up is it actually doesn't have as many sodium channels, so it doesn't depolarize as fast. Yeah, I think that doesn't depolarize as fast. So you get almost like a pause here of about, I think it's 0.1 second from memory off the top of my head. And that actually allows time for those atria to empty and those ventricles to fully fill with blood so we can pump as much blood as we need around the body. So that's why we get that little bit of a delay or that isoelectric line, because no electrical activity is really going one way or another. It's kind of sort of slowed down here and then it'll keep on moving on. And that's where our QRS complex comes in. So that is sort of through our bundle of his, down our left and right bundle branches, and then shooting back up through the ventricles here and into all of our Purkinje fibers. So that's that QRS complex. And the reason it does this sort of weird squiggle is to start with, you find that left bundle branch actually helps to depolarize the septum and set off the right bundle branch. So you end up getting a vector that looks a little bit more like this. So you got a bit of a vector. Might change colors on pens. Let's go blue, hey? You end up with a vector that kind of ends up looking a little bit like that because of the way that left bundle branch will start to depolarize and help with that septal depolarization. So you end up with a vector like that. And remember, if we've got negative up here and positive down there, that's almost opposite towards that positive electrode. So we get a negative deflection to start. But as that signal comes down and starts to spread out down here at the apex of our heart, those electrical signals are heading sort of towards, we get an overall net vector towards that positive electrode. And the reason it's sort of deflected a little bit more towards the left side of the heart than the right is that left side is thick with a triple C. It is very, very thick, a lot more electrical activity compared to that right ventricle. So because that positive depolarization is heading towards that positive electrode, we shoot back up and get a positive wave. And then lastly, that signal is coming around and going back up those walls of the ventricle, and now it's heading back towards that negative electrode. So if it's a positive depolarization heading towards a negative electrode, we end up coming back down and getting that negative deflection of our S wave. And then lastly, we get ventricular repolarization, which is this T wave here. And it's what we were speaking about earlier when I drew up the 3 different boxes. Because repolarization, think of it like a negative charge or a negative signal heading back towards that negative electrode. 2 are the same thing, 2 negatives, we get a positive deflection. So this one here is ventricular depolarization. This one is ventricular repolarization. And that is the basics of a normal ECG taught in, I think, about 20 or 30 minutes. So if you know all of that, if you take one thing out of tonight, take this out of tonight. This is how an ECG works. This is what a normal one works like. Now we're going to actually go through and we're going to follow the AMBOSS website here. And I love this guide right here, Approach to ECG Interpretation. If you follow this, you will get out of trouble every single time a consultant hands you a danger squiggle, sorry, an ECG. I love calling them danger squiggles. If anyone watches Dr. I think it's Glaucoma Flecken, I can't pronounce his name. Hilarious guy. He's dubbed them danger squiggles, and I think it suits. Jill has a question. When does atrial repolarization occur? That is a really, really good question. It actually occurs when this QRS wave is occurring. So atrial repolarization will occur at the same time as that ventricular depolarization. But remember, we said because the atria are so small, we kind of get just that little blip here. That QRS, that ventricular depolarization, actually hides what's going on with the atrium. So it is repolarizing here, but you're not going to see much because the electrical activity of the ventricles is sort of dominating and it takes over the ECG. Let me know if that answers your question, Marjol, in the chat. Otherwise, I'll come back to it, but we'll keep moving on just so we get through everything in time. So I'm going to follow this approach here, and I'm literally going to take us through everything on the website here and go through a few examples, some normal examples and some examples of things that are going wrong. So if you follow this, the first thing you need to do is know the patient's clinical picture. So to do that, step number 1 with ECGs is always check you have the right ECG because things do get mixed up. Check your patient details and then check why the patient came in. Was it for shortness of breath? Do they have a crushing chest pain like an elephant stepping on their chest and an impending sense of doom? Is it just when they're exercising? Are they waking up from sleep because of it? Check what it is that's brought them in because 9 times out of 10, that will give you a pretty good idea of what might be causing it and what you need to look for on the ECG. Obviously, be wary of biases because that can influence what you're looking for. And that's why if you follow this step-by-step procedure, you won't ever miss anything. But it's always good to know what's going on. The next thing you need to do, I'm going to jump over here, is check your calibration. So I've taken this directly from the AMBOSS website. Generally speaking, your ECGs will run at about 25 millimeters per second, which means for every one of these little itty-bitty small squares, that's equivalent to 0.04 seconds or 40 milliseconds of recording time. Now, one of these little squares, if you have 5 of them, they make up one of these big boxes. So one little square, one of these, so you got 1, 2, 3, 4, 5 in a big square. So every big square is 200 milliseconds or 40 times 5. That's really important because we always check how wide or how long each wave goes for. And sometimes when things go wrong with the heart, these waves can get longer or shorter. So you need to be able to count how long each wave is, or at least know how many little or big boxes each wave should be. The other thing you need to check is it calibrated to a voltage of 1 centimeter or 10 millimeters is 1 millivolt. And what that means is every little box here, every time it goes up one little box, that's recording 1 millivolt of electrical activity. So 1, 2, 3, 4, 5. One big box is then, sorry, not 1 millivolt, 0.1 millivolts is every little box. And then 1, 2, 3, 4, 5 is 0.5 millivolts. 5, 6, 7, 8, 9, 10 is 10 millivolts. 10 times 0.1 millivolts, which is 1 millivolt in total. Ugh. So one little square, 0.1 millivolts. 10 little squares is 1 millivolt. And we use this a lot when we're looking for things like atrial enlargement or hypertrophy, as well as like left ventricular or right ventricular hypertrophy, because really big muscle, really hypertrophied muscle is going to change things and make them look almost like this. Right up here, you get really big skinny waves that go right up and right down. So that's one of the things you can look at as well. If you don't check your calibrations, sometimes they're not calibrated properly and things can look a little funky. So always check it's running at 25 millimeters per second and 1 millivolt per centimeter or per 10 millimeters. The next thing you want to do is assess the quality of your ECG. And what I mean by that is you don't want an ECG that looks like this. This is what happens when you give someone a precordial thump. So you get your hands together and you whack them in the chest. You get a lot of artifact and you can't see what's going on. So if your patient's sitting there and they're hypothermic and they're shivering, it's going to leave lots of wiggly lines all over your ECG. Just as like if you've got a little newborn baby, they're going to be squirming and wiggling around, you're going to get lots of artifact and wiggling and squiggling, and it makes it really hard to interpret your ECG. So you always say to your patient, lay still while this 10-second recording is going, as much as you can to your patient. Sometimes little babies, you kind of just have to get mum or dad to hold them still. We already spoke about checking that the leads are correct with our AVR and our lead 2, but the last thing you need to do is have a look for any life-threatening abnormalities or anything that's really obvious where you got to grab your reg or your consultant really quickly. So things like your VTAC, ventricular tachycardia, your ventricular fibrillation, asystole, you definitely don't want to see that. Even STEMIs, you want to grab someone really quickly, and we'll go through what each of those look like as we move on. So let's now go through the AMBOSS website and do our ECG interpretation. So the first thing that we do is we work out our heart rate and our rhythm, and I'm going to close that down. Now, one of the really good things about AMBOSS is you can turn on this highlight thing here. I think a few people said they weren't sure, or they didn't have a lot of guidance about what to learn. This highlight shows you the really important or the key stuff to make sure you're learning. Like, I love it. It tells me what I need to know when I'm quickly on I'm on the wards and someone's asked me a question and I don't know, and I'm like, oh my gosh, I got to read through this and find it, put highlight mode on. It draws my attention straight away to the key information. So that's really useful. The other thing you can do too, I like to go through and read everything when I learn from AMBOSS. And then when I review it, I tend to go back and I just review the high yield stuff. So see how it's shrunk a bit of that text? It's just left the high yield stuff, which is generally the highlighted info. So if you like to have everything up all at once, leave the highlight on. It'll show you the important or the key info you need to know. If you don't like a wall of text, then you can just chuck high yield on, and that shows you that key info when you're referring back to it. So I really like that feature. I find it really helps when I'm on the wards and I don't have time to read through a heap of information, which I have time more to do when I'm at home studying on AMBOSS. So to work out our heart rhythm, basically what we're doing is we're looking at how regular our P waves and our QRS complexes are and looking to see if they're regular between the two. Now, most of the time, you're just going to have a look at those QRS complexes and try to work out, is that interval between the two the same distance? So if we pop one of these up, let's have a look. I like this one to start with. Let's close the caption and I'll zoom in. So that's another great thing about AMBOSS is you can use this tool here, or you can just scroll with your mouse to zoom in and out, and you can drag it around. So it makes it a bit easier to actually have a look at that ECG. So I'm going to zoom in and I'm going to have a look whether these QRS complexes here, so these big pointy bits, are nice and evenly spaced apart. And what do you think, guys? Looking at this, do they look like they're pretty regularly spaced apart? Does that rhythm look pretty regular here? So do they look like they have the same number of boxes between each of them? So just give me a yes or a no in the chat if you think it's regular or not.
Oh, we'll just wait maybe quickly.
That's all good.
If some answers are coming in. There's also a really good trick that you can use in the hospital with a piece of paper and a pen. Does anyone know that one? People say yes, but I think that's more to your question.
Did you want to share that one, Kim?
Yeah. So basically, if you're in the hospital, you can just grab a piece of paper that you would lay over your ECG, and you just grab a pen, and on that white piece of paper, you lay that just under your R waves or R depolarizations, and then you can just make little lines on the paper, and then you can move the paper along the ECG, and you can see if that is in equal distances every time. So that's a pretty quick way to do it on the wards as well.
Excellent. Yeah, it's a great tool. And it's also really good too if you you can also mark your P waves down as well, and you can check that they're lining up too. So there's a condition called third degree AV block, which I'll show you guys, but we won't chat about too much because it's pretty advanced. Maybe if there's we do an advanced ECG workshop at some point, we'll go through that. But that one, you're looking at to see if your P waves and your QRS complexes are actually sort of firing off at different times. And it's a really easy way to help detect that, or I found it easier. But yeah, really good tool, guys, the sliding paper that Kim mentioned there. Cool. So yeah, this one is nice and regular. It's got about 1, 2, 3, 4-ish boxes between them. Again, 1, 2, 3, 4. And obviously when you're doing this, you go through and you'd sort of check all along the rhythm strip. So I always like to use the rhythm strip, that bottom strip of 10 seconds to do it. What about, let's say, oh, I don't think I have it on here. That's okay. I've got it on my PowerPoint. What about this one here? So what do you think about this one, guys? This is also from AMBOSS, but it's I'm not going to say where I got this one from because we'll have a chat about what this condition is shortly. But what do you think about that? Does that look regular or does it look irregular, those heartbeats, those QRS complexes? Kylie says irregular. I would 100% agree with you. Over here, they're sort of, oh, what's that? Maybe 3.5 apart. That's about 3.5. Now we're 4, 4, back to 3.5, down to about 3. Oh, now we're 2. Now we're 3. Now we're 2.5. Now we're, so it's sort of all over the place. And there isn't really a pattern to that irregularity either. So this is what we would call an irregularly irregular beat. There's no pattern to how they're coming out. It's irregularly irregular. Whereas before, they were coming out about 4 big boxes apart every single time. So we call that regular. The only other thing that you need to work out with your rhythm is whether it's this thing called regularly irregular. And this is very common in your AV blocks, where you might get, say, 2 or 3 beats, and then you drop a QRS complex. And then you get 2 or 3 beats again, and then you drop a QRS complex. So it has a pattern every time it drops that QRS. So we call it regularly irregular. It's not completely regular, but it has a pattern to its irregularity. Whereas that last one we saw was irregularly irregular. Now, the reason you should work out rhythm before you go and do rate is for these two here, these ones, you can use pretty much any method to calculate your rate. Whereas for this one, you need to use a specific method. And those methods, if we jump back over to the AMBOSS website and scroll down to our determination of heart rate now, is one of these here. So for a regular heart rate, the best way I found to do it is this one highlighted in yellow. You take the number of large boxes between each QRS complex and you divide 300 by that number. So if there was 3 boxes between each QRS complex, 300 divided 3 means you got a heart rate at around 100. You can also do it using the irregular method, where you just go along and you count the number of QRS complexes on that rhythm strip and you multiply it by 6. The reason we multiply by 6 is it's a 10-second strip. Multiply it by 6 gives us 60 seconds, which is a minute, and we calculate it as heartbeats per minute. So that's why we multiply by 6. With your irregular rhythm, though, you have to use this method here because the heart rate would change depending on which two QRSs you calculated this one between if you were to use this method. So a regular rhythm, you can use either one, and a irregular rhythm, you need to use this one. So let's go ahead and actually do that. I'll pop up. We go back to this one. Oop, it's going to give the answer away. I'm going to hide that. If we have a look here, and I'll zoom in again. If we count the number of boxes between these, so I've got 1, 2, 3, 4, because we know it's regular, you can pick anywhere along this strip. I like to try and find when it starts on a big box and then count along. It just makes it easier. So I've got 1, 2, 3, 4 big boxes. 300 divided 4 is about a rhythm of 75 beats per minute. And that's what our answers say here, or our caption here. So AMBOSS is great. Every ECG pretty much has a caption. Some of them even have drawings over the top to highlight the important features, which I'll show you in a few other examples. But it gives you all the info you need. So it's great practice to look at these, practice working out all the different parts of the ECG, and then check the caption and see if you're on track or not. So if we go back to, or actually if I give you guys one, can you calculate this one for me? Yeah, this one here. So, oh dear. What do you think? Oh, that's zooming in and out. What do you think the rhythm is going to be? Oh, sorry, the rate is going to be for this one here. So I'll give you guys a little bit. See if you can throw an answer up in the chat. What's going to be our rate for this one here? Just so you know, this one's a bit weird looking. These are actually a big box. Each of these little ones here are the big box. So there's 5 little teeny tiny ones. I'll zoom in a bit further for you. It's a bit of an odd ECG paper, this one. But that's one big box. That's another big box. The really big dark lines is like your big box. So 1 big box, 2 big box, 3 big box, 4 big box, 5 big box, 6 big boxes, if that gives people a bit of a hint. So anyone got an answer for that one? That's all good. Oh, Michelle's got one. Nice. Yes, Sarah's got one. Sarah, I love that you've put bradycardic there. Awesome. That was going to be my next question. You read my brain. So like I said, this is a bit funky. It's a bit of a weird looking sort of ECG paper here, but you can see 1, 2, 3, 4, 5 little boxes make 1 big box. R wave, count those big boxes. 1, 2, 3, 4, 5, 6 big boxes. 300 divided 6 is about 50. And I think, yeah, they calculated about 47. So it gives you a rough estimate. And as Sarah said, this is bradycardic. So anything below 60 beats per minute, we consider bradycardic. Anything above 100 beats, we consider tachycardic. So we would say this is a sinus bradycardia here, just because it has sort of, you've got your P wave, your QRS, and your T. It's a normal looking wave, but it's a bradycardia. The last example I'll quickly work through before we move on to our next topic is this irregular one here. So we can see these QRSs are quite irregularly spaced out. So what I need to do in this instance is I count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. So, and multiply 13 by 6. So that gives me 60 plus 18. I do maths weird. So that's 78 beats per minute. Some people can do that straight in their head. I've got to break it down a bit. But yeah, so that's how you'd work this one out, because we can't just calculate between here. That would be different here to, say, this one here that's further spaced out. So that's our rate and our rhythm. Now let's move on to our cardiac axis. So that's the next part in our step of things we can do for working out our ECG. So determination of our cardiac axis. Basically what the cardiac axis is, big wall of text here, but the main thing you need to know is it's calculated using this thing called the Cabrera, I can't pronounce it, circle, which looks a little something like this. And you'll see it was highlighted. We use leads 1 and AVF method. That is the best way to calculate it. There's other ways you can do it, but this way I think is the best because it's the easiest and it's pretty foolproof. So we look at what's going on in lead 1 and lead AVF. Now, we would expect both of these to have positive looking QRS complexes because the only lead we really expect to see negative ones is in that AVR lead. So we go and have a look and we go, well, what's going on in lead 1? It's looking positive. So I'm going to draw my lead 1 the way I would expect it to look. Then I go and have a look at AVF, and I know because it's a positive QRS here, AVF is pointing in the direction it should be. If we think way back to that precordial and chest leads, the way those leads were set up. So it's pointing the way it should be. This means if we draw a resultant vector, dragging it across the screen, a resultant vector between the two, it'll fall in this area here. So if I jump back to PowerPoint and draw this up. So if my lead 1, cannot spell, lead 1 is positive QRS and my AVF is positive. We remember how that diagram looked before. We had AVF here and lead 1 here and lead 2 and lead 3. We would expect lead 1 and AVF to look like this. So lead 1 and AVF. So the resultant vector between the 2 points here, that means that axis is falling in the normal QRS axis region. If, however, maybe my lead 1 was actually negative, so my QRS complex looked more like this than it did something like this, what I would do is I would take this lead 1 and I would draw it negative or back to front. So I would draw it over here. This is like negative lead 1. And if we draw the resultant vector this time, it's now falling in this quadrant. So we get what's called right axis deviation. And that's the same thing with if we had a positive lead 1 and say a negative AVF. So a positive lead 1, but AVF is back to front or negative, we get a vector over here, and that shows us left axis deviation. And basically what that's telling us, if we have a look through AMBOSS here, some of the reasons we get these things like left axis and right axis deviation is because we're getting more of an electrical signal over on the left side of our heart. So things like left ventricular hypertrophy can cause that axis to deviate towards the left side, left bundle branch blocks, and kind of, how do I explain this? It's kind of almost the opposite in a way with if you get an inferior myocardial infarction. Now that means you've sort of knocked out the right ventricle in a way, that right coronary artery or your posterior descending artery. You're not going to be getting enough oxygen to that right ventricle. Because of that, it's not going to be beating as well or firing off that electrical signal as well, which means the left signal dominates. So again, that can also give you an indication to MIs, not just hypertrophy of a ventricle, but it's one of the things we do look for when we're looking for left and right ventricular hypertrophy. And it's the same thing with right axis deviation. So you'd be looking at things like right ventricular hypertrophy or right bundle branch blocks are really well shown with that right axis deviation. So if I pop a few examples up for you, if we have a look at this one here, what we can see is we go to that lead 1 here, and we can see lead 1 is normal, is like upright, And then we have a look at AVF, and AVF is upright. So if I draw that up on my PowerPoint, my lead one is, let's get rid of all of this. Pointer options, let's erase all that pen. Lead one is where it should be, it's positive. Lead AVF is where it should be. That's telling me that this ECG has a normal axis deviation. And if we look at the caption, yeah, it says a nice normal axis. If, however, maybe we have a look at, let's see, what's a really good, there's a really good one back here. What do you guys think this might be? So I'll give you about 10 seconds to have a quick look, or at least tell me which one looks a bit odd. There's one of those leads that look a little bit off here. So between that lead, I'm not going to say them, which lead might look a bit off, or if you want to have a guess, what kind of axis deviation might we have here? Give you guys a bit of a hint. This lead one's looking pretty positive to me, so that's pretty good. But this AVF here, that's looking pretty negative. So does anyone want to have a guess what kind of axis deviation we might have if our lead one's positive, but our AVF is pretty negative? I'll jump back over to the PowerPoint where you can see it here. Dylan says lad. Yeah, nice. Moore says lad. Perfect. So we've got a positive lead one, but our AVF had a negative QRS here, QRS complex. So we need to draw that up here, and we get left axis deviation. And that's what you'll find. This one here has that left axis deviation. So that's how you guys can go ahead and calculate axis deviation. Alrighty. Now we're into the good stuff. Let's go through all of those waves and segments we were talking about. I'm probably going to work through these ones, not throwing as many questions to you guys, just so we make sure we get through everything in time. But I'm going to go through each of the really key abnormalities that you should know for each of these waves going into your clinical years. There's more you'll learn during clinical years, but going into it, the big ones you need to know. So remember that P wave represents your atrial depolarization. You should see it in every lead. It'll be positive in those 1, 2, and AVF. So always 2 will be positive. But remember we said because that electrical signal is going the opposite way to our lead AVR, it'll actually look upside down in AVR. But that's perfectly okay. Now, with your P wave, it shouldn't be any longer than about 0.12 seconds, or if we remember, each individual little square is 0.04 seconds. So I remember 3 little boxes should not be any longer than 3 little boxes, and not higher than 2.5 little boxes, because each little box in terms of amplitude is 0.1 millivolts. So if we pop up a nice little diagram here, we can see that this is what a nice normal P wave looks like. It's, what's that, about, I'd say that's probably about 2 boxes or just under 2 boxes. We got 1 box here and about 1.25 of a box. So 1 3/4 of boxes wide, and it's only about 1 1/4 boxes high. So it's definitely got an amplitude smaller than 0.25 millivolts, and the duration is under 1.2 seconds as well. So that's all good. However, you can get this thing called P pulmonale, and I've been asked to identify this before, and my brain just went completely blank, but I went, it's big, which kind of got a weird look from the consultant, but he's like, yes, it is big, and I couldn't remember what it was, but that's okay. I looked up on AMBOSS after. But I was able to identify that it was a really big, tall P wave, which meant there was something going on with my atria. And what causes this really big, tall P wave is going to be your right atrial hypertrophy. So if we go back to here, AMBOSS has got a great summary table of some of the abnormalities of our P wave. That right atrial enlargement that we can see, often caused by lung issues, because the right ventricle's got to beat really hard, or you've got blood backing up and it's expanding that right ventricle and that right atrium. They've got to contract harder to get the blood through that pulmonary circuit. things like your pulmonary hypertension, you can really see that. And your COPD, you can see that right atrial enlargement occurring, and it looks like that P pulmonale that I just showed you, that really big P wave, because that atria's had to get bigger. The next thing you can spot is, I love this one, the double camel hump here, or the camel hump, the double bump. This is your P mitrale, or I'm probably butchering how to say it, but this one here is left atrial enlargement. The reason we get that sort of camel hump is because the left atria has now had to enlarge for a certain reason. It's taken a little bit longer to depolarize, and you get that second bump. They don't sort of go together. So that's another really common abnormality you might see. The last one you might see is one I showed you guys earlier, and I'm going to pull that one up. This one here. Can anyone tell me, what is my P wave looking like here? Or can anyone even point out a P wave to me? And I'm a bit of a jerk. I'm sorry, guys. There actually isn't any P waves here. So for anyone who was looking at that going, oh my goodness, where is the P wave? Nice, Dylan, you got it. You said gone. There's no P waves here. And this one here, if you don't see P waves and you've got an irregular rhythm, you pretty much are going to say this looks like atrial fibrillation. And that's one of the other key things. You should always be able to identify this going into third year. No P waves, irregular rhythm. That would be atrial fibrillation. So that's our P wave summed up. They're the key things: P mitrale, P pulmonale, and atrial fibrillation. Definitely make sure you know those going into third year. The next thing we're going to look at now is our PR interval. So the PR interval is from the start of that P wave to the start of your QRS complex. So it includes that atrial depolarization, as well as that sort of pause we get at the AV node, that pause that allows that atria to completely empty so the ventricles can contract as much blood as possible. Now that PR segment, if I jump down here, so P wave through to the start of that QRS complex, this here is your PR interval. And this little segment here, this flat line, is your PR segment, known as the isoelectric line. And this is really important. We use this as a reference for our ST segment when we're looking at elevation and myocardial infarctions. So really important that you compare these two when we get to looking at the ST segment. But what we're going to look for here is, as AMBOSS has shown us just back up above, it shouldn't be any longer than about 0.2 seconds. So from the start of that P wave to the start of the QRS complex shouldn't be any longer than one big box. So that's nice and easy to remember. 0.2 seconds is 5 little boxes or one big box. If it is, it means you may have something like first degree AV block, or even any of these second or third degree AV blocks as well. And we'll go through a quick look at each of those, but not in too much depth. The big one you should know is this first degree AV block. So we can see that P wave starting here, but the start of the Q wave is over here. So we've actually got one big box, so about 6.5 little boxes there. So that's greater than that 0.2 second time that it should be, which means we've got atrioventricular, first degree atrioventricular block. It's taking longer to get that signal through. Another common one that comes up is your type 2 or second degree atrioventricular blocks, and there's 2 different types. And I'm probably going to butcher the name, but I always called it Wenckebach. Apparently it's Wenckebach, but someone told me
it's actually German. It's Wenckebach.
Wenckebach. Oh gosh,
no one can say that.
Sorry, Kim.
No, I would struggle so much with that as well.
Yeah, someone told me Wenckebach, and I've never been able to say it properly, but yeah, Wenckebach. And this is one where box sounds like drop, or I remember it that way. You actually get an extension. So every complex you get, or every sort of heartbeat, you find this P wave, or this PR interval gets longer and longer, and then eventually you drop a QRS complex. And it goes back to the beginning again, and it'll get longer and longer and drop 1. So that's your type 1, your Mobitz type 1 second degree AV block. And your Mobitz type 2 is that, remember we said there was regularly irregular patterns? This is where you'll get a nice normal QRS complex, PR interval and QRS complex, but then you just drop 1. And then you might get another one, and then you drop 1 again. So you can have patterns where it's what we call 2-1. So there's 2 here, but one of them's dropped it. You can have 3-1, where you get 2 normal sinus sort of beats, and then you drop your QRS complex. There's lots of different types. But if you're able to identify that there's a regular pattern there, that's probably all they expect at this level. There's also third degree AV block, but we won't cover that tonight. That one gets a little bit more complex. The big ones you should know are these second degree blocks. So longer drop. Or you can have that pattern of you have 1, you drop 1, or you have 2, you drop 1, you have 2, you drop 1. And your first degree. If you guys like, I love this. This is one of my favorite things, the heart block poem. You just Google it. It actually is a really good way to remember. It has sort of a poem that rhymes. This is how I learnt it. I love it. That helped me to remember it when I was learning this. All right, guys. And if you guys have any questions, please feel free to throw them up in the chat. Ready to answer them. Any that come through, or Kim can answer them. So last thing I will show you on that PR interval is here's an actual ECG reading that you can see here. And if we go in and we count it, we've got 1, 2, 3, 4, 5. Yeah, it's right on the cusp there. Whoop, now we've got 1, 2, 3, 4, 5, 6, 7. 1, 2, 3, 4. I'm not going to even count those. Oh, my computer's freaking out. There we go. So it's getting short, longer, and we've dropped 1. So this is going to be that Mobitz type 1. So second degree AV block, or Mobitz type 1, or Venkiback as we call it. So that's an example of an actual ECG output of it. Alrighty, so we're up to our QRS complex. We're kind of halfway through these waves now. So your QRS complex, remember we said it represents that ventricular depolarization. So if you get handed an ECG and the QRSs look a bit funky, even if you have no idea what's going on, you can say, look, the P wave looks normal, the PR interval looks pretty normal, the T wave looks normal, but that Q wave is not looking right. It's looking pretty funky. I think something's up with one of the ventricles. I'm not sure what, but it looks like there's a ventricular issue. That in itself that'll impress your consultants at the start of your clinical years. They'll be happy that at least you've had a go and you've been able to work out where the problem is. And they're probably more likely to actually then walk you through what the problem is rather than you going, oh, I'm not sure. So always use this method. Even if you can't work out exactly what the conditions caused, at least you can work out where things are going wrong. So if our QRS complex is looking a bit funny, it means something's going wrong with ventricular depolarization. It should be less than, usually it's typically about 120 milliseconds. So again, 3 little boxes. So that P wave and that QRS complex, both of them should be around or less than that 120 milliseconds. So nice and easy to remember. They're both about the same. So it's nice and narrow. And what you find is your R wave, this is probably the most important thing to remember, your R wave should progressively get bigger as you move from V1 through to about V5. So if we actually pop an ECG up here, I'll go to this one. Here we go. So what we see is as we move from V1, V2, V3, V4, V5, V6, that R wave should be getting progressively bigger. See how this is getting progressively bigger as we move along and getting progressively more positive. It should do that because that's how that axis of electrical activity would line up if the heart is nice and normally structured. Now, the other thing that we have to check is that this complex here is no more than 3 little boxes wide. So I can see on this one, we've got 1 box here, 2 boxes here. So that's under 3 boxes. It's what we call a narrow QRS complex, and that's normal. We want them to be narrow. they tend to be wide in conditions like left bundle branch block, right bundle branch block, your myocardial infarctions, your ventricular tachycardia. That's where they're really wide and abnormal. And that wideness means that it's taking longer for your ventricle to depolarize. It shouldn't take long. Those bundle branches and your Purkinje fibers are like the highway of electrical charge. It should be flying down that. So that's why this is so narrow, and normal is narrow, if that helps you to remember. Things you want to look out for, like I said, really wide QRS complexes. So if I show you one like this, you guys can see these are quite wide, very, very wide QRS complexes. If I zoom in, you can see here we've got, what's that, 1, 2, 3, 4.5 boxes, or one, if I count this one here, I'm going to zoom in a bit more because it's a little bit difficult to see. If we count over here, we've got 1, 2, 3, sort of 4-ish boxes. They're getting quite wide, and this is because they've got what's called a left bundle branch block. Something that we won't cover tonight, but something that you can definitely, maybe in a future more advanced session, would be good to cover, whether your uni runs that or whether AMBOSS runs one. But that's something that maybe by 4th year you should know, a bundle branch block. But being able to look at that and go, not quite sure what's wrong, but those QRSs are wide, that's a big thumbs up from a lot of the doctors on the ward. So that's the first thing you want to look for. Is it narrow or is it wide? The next thing you also want to look for is what we call a pathological Q wave. And what that means is usually this little Q wave here should be nice and teeny tiny if it's looking pretty big. So generally, if this is more than 1/4 of the size of the R wave, that's telling you that it's pathological. And what that can be an indication of is a number of things. So like the big one you want to look out for is a myocardial infarction. You will often see a lot of pathological Q waves when you have a STEMI. You also see it in a few other conditions as well, but the big one that's been bolded by AMBOSS is that myocardial infarction. So I think they've got an example here that shows a pathological Q wave from memory. Where is it? There was one here before. Let's try to find it again. Oh, I can't find it. I do have an example later in the slides though. But yeah, that's sort of your Q waves. You want to make sure they don't have that big pathological Q at the start. You want to make sure that they're progressively getting bigger and bigger as you work your way through the leads. That R wave is getting bigger. The last thing you can also check for is what we call hypertrophy. So we checked for it before using left axis and right axis deviation. The other way you can check for it is using this criteria called the Sokolow-Lyon, probably said that wrong, line, I'm not sure, criteria, where we look at R waves and S waves in leads V1 and V2 and V5 and V6. And they're back to front for left and right. But ultimately, if you add, say, let's do a left ventricular hypertrophy, I would look at my R waves in V5 and V6. And then I would look at the size of my S waves in V1 and V2. And if they add together to be more than 3.5 millivolts or 35 millimeters, or we could also say, what's that, 3.5 big boxes, then that means I have left ventricular hypertrophy. Now, personally, I find using left axis and right axis deviation easier to give me a hint whether there's hypertrophy. But this confirms if there is or isn't. So left and right axis is kind of like almost like, think of it like a screening test, gives you an idea, and then this will help you confirm it. So a really good example of that one is over here. And this is where I'm going to show you that overlay feature of AMBOSS. So it's actually gone and picked that S wave in V2 and shown us just how big it is. So if I count boxes, we've got 1, 2, 3, 4, 5, 6, 7, 8. So that's, wow, that's a lot of boxes there. That's a really, really big S wave. So that in itself has already almost met the criteria. And then we can add the R wave in V5 and V6. So this one is 1, 2, 3.5 big boxes there. So together, they meet that criteria of being greater than 3.5 millivolts. And it's just the opposite when you're looking for right ventricular hypertrophy. You'll look at R in V1 and V2 and S in V5 and V6. So that's a good little way to confirm whether they have hypertrophy or not. Cool. Alrighty, so we're almost at the end, guys. We've just got 3 more things to go through, and then we're going to have a few questions to win that AMBOSS, those subscriptions. So we'll probably be about another 5-10 minutes here. The big last thing I want to cover is your ST segments, and this is like your standard medical school exam question. You will always get something on the ST segment. There'll be some ECG that has ST segment elevation on it. So our ST segment, if we go back to, I'll have a look at a picture here, is this segment here. So between our S wave and the start of our T wave. Now, normally, because we've depolarized our ventricle and we're about to repolarize it, it's isoelectric because there's kind of like a pause. Nothing's really happening at this point. What we see is that repolarization of the septum and the depolarization of the ventricular walls kind of cancel each other out. So that's why it stays isoelectric. However, in STEMIs, which is your myocardial infarctions, the way the physics works is essentially you get this elevation of the ST segment. And it's, without confusing anyone with the physics, it's actually not so much an elevation, but more your ECG tracing actually shifts, because when nothing's depolarizing or repolarizing, the ischemic area actually generates an electrical signal, and that will shift the tracing up or down. That aside, ultimately, it results in this elevation of that segment. But there's a really good article on, I think it's Life in the Fast Lane, that goes through the shift of the ECG tracing itself and why you get an elevation and a depression. But if you don't want to learn the physics, that's totally fine. I only learnt it this year anyway. I put it off a bit. But that ST segment elevation is a really good indicator that you have a myocardial infarction. So you have a thrombus blocking one of your main coronary arteries. And remember at the start, we spoke about how different leads represent different parts of the heart. Well, that's essentially what we look for when we check STEMIs. So if I jump back to my PowerPoint, all these different pictures, and I'll release these slides. All these pictures are from AMBOSS. We went through that before. I'll come back to those ones in just a second. This ST elevation here, we look at where it's occurring, so which leads it's occurring in. Now, if it occurs in those inferior leads, those leads 2, 3, and AVF, that is telling us, so if there's elevation in these 3, that's telling us that, hey, maybe something is going wrong with either my right coronary or my posterior descending artery. Maybe there's a blockage in one of those somewhere, because that right coronary artery kind of comes around and kinks down like that, and that's your posterior descending there. If you see ST segment elevation in your lateral leads, so leads 1, AVL, V5, and V6, so if we remember the one that's pointing like this, and if we draw our heart here, we had V5 and V6 over on the side here, 1 and AVL, all pointing to the left. That means you may have an issue with your left circumflux artery, which supplies that lateral left wall of the heart. And then lastly, your anteroseptal leads, V1 to V4, that corresponds to your left anterior descending artery, or the LAD as everyone likes to call it. Don't get that mixed up with left axis deviation. So if you see elevation in those leads, that's probably indicative that you've got a blockage in the LAD there. So if we jump back to AMBOSS here and we pop up some examples, I'm going to quickly hide that. What do you think, or I'll go through this one and then I'll get you guys to tell me the next one. So if I look at this one and I've checked everything else and I have a look and I go, well, let's see which leads I can see some elevation in. I can see it in V1, definitely. That's a big ST elevation there, because comparing it to my isoelectric line, so here, That's my isoelectric line. That is elevated. I'll just zoom in a little bit for you guys. Whoop, no. There we go. So we can see isoelectric line, that is elevated above that. Same as if I look here, oh, that's a really big elevation there. Isoelectric line, really elevated. We can see that leads V1, V2, V3, V4, V5, and V6 all have this really big elevation there. And that's a really good hint. If we come over here and have a look at our other leads, I can also see that in my AVL here, I've got my isoelectric line, and then we've got this ST segment that's elevated. So again, AVL's got ST segment elevation, and lead 1 has ST segment elevation. There's a little bit in AVR, but generally we don't tend to consider AVR when we're looking at it. But there's not much happening in leads 2, AVF, and leads 3. So what this is telling me is I've got something that's setting off leads 1, AVL, V5, and V6, so lateral leads. Something that's setting off leads V1, V2, V3, and V4. So if I jump back to my PowerPoint, so lateral leads have been set off. Inferior leads, not inferior leads, sorry. Anterior septal leads are also showing STEMIs. That means it's probably something that's knocked out both my left circumflux and my left anterior descending artery. Both of those have been having an issue with the blood supply because of the ST elevations in these leads. And this is a really common finding if you have a very proximal left anterior descending thrombus or myocardial infarction. So if you have a blockage right at the proximal part of the LAD, or even in the left coronary artery, which supplies both of those, that's when you'll see elevation in those lateral and also anterior leads. So I'm going to let you guys have a quick go on this one. Which leads can you see ST segment elevation here? And which aspect of the heart or which vessel do you think it is that is having the issue? And as Kim said, yeah, that's a really important point, Kim. Those ST segment elevations, they can't just be randomly all over the place. They have to make sense. They have to match up with those groups of leads. You can't just have one in lead 1 and one in V5 and one in AVF. It actually has to match up with those groups of leads. So what are we thinking, guys and girls? Where can you maybe see some ST segment elevation? Can you chuck some lead names in the chat? I'll start you off on one. I can see definitely, if that's my isoelectric line here, we have some elevation in AVF.
Yeah. Another maybe good point is as well to look for that ST elevation really coming from the descending R wave. So that's what you're kind of looking out for. Yeah, definitely. Oh yeah, we have some answers coming.
Excellent. Yeah, inferior. Nice, guys. So yeah, we can see it in lead 2 here. So that's my isoelectric line there. We've got some elevation, isoelectric line, elevation. So leads 2, 3, and AVF are definitely showing ST segment elevation. And you're spot on for those who've said inferior leads. Perfect. And I think someone said RCA. Yeah, nice, Joanna. RCA, maybe it's PDA. There's different ways to work that out, but we'll leave that for another session. But yeah, one of those inferior vessels or that inferior wall of the heart is being affected. There's also things you may hear about reciprocal depression. I'm not going to cover that today, but you can also confirm this by looking for what's called reciprocal depression. And if you want to know what that is earlier than or before another session, definitely recommend reading through this ST segment area on AMBOSS because it covers that too. All right, last thing that we'll cover, guys, is just the T wave. We might just skip over the QT interval tonight because generally we don't tend to worry about that too much unless it's for specific situations. But your T wave is the last thing that you really should know and be familiar with before you get to third year. So this one represents our ventricular repolarization. And the things you need to look out for in this one is you want it to be less than 10 millimeters, so less than 2 big boxes. So if we have a look here, it needs to be less than those 2 big boxes. If it's bigger than that, you've got something funky going on. So this is a nice looking T wave. Sometimes you'll also get a second blip after it that kind of looks like a P wave, but it's what we call a U wave. Sometimes they pop up every now and then. But from memory, I think it's hypokalemia that they tend to pop up in. Yeah, hypokalemia or hypocalcemia. It's usually due to some electrolyte abnormality, and that's also why we tend to get what's called peak T waves or flattened T waves. They're the big high yield things you should know before third year, is seeing peaked or flattened T waves. Now, flattened T waves, if you flatten something, you're making it low and squishy. I remember it's your hypos for your lows. So low flat T waves, hypos. Things like hypokalemia, hypoglycemia, and hypothyroidism. Sometimes in your MIs too, but the hypos are your big indications that, or your T wave being flat, could give you an idea that this is happening. And a lot of the time, you'll just then supplement with IV glucose or potassium. With your peak T waves, though, these are things like hyperkalemia and hypermagnesia. I can never say that word. These are a bit more worrying, particularly your hyperkalemia. So if we have a look here, if you're seeing a T wave that looks like that, when you start to see ECG changes, that means that your potassium is really high. And often we then have to give them this thing called calcium gluconate to try and get rid of that excess potassium, because it can lead to arrhythmias. So hyperkalemia, a really good example of that is this ECG here. We can see that we've got these really peaked T waves. They're definitely, what's that, 1 box, 2 box, 3 and a bit boxes tall. Hyperkalemic T wave there, peak T wave. Whereas on this one here in hypokalemia, we can see that those T waves are very, very flat. So if I kind of have a look for one here, very, very flat T wave, very, very small. Awesome. The only other thing I wanted to quickly show you guys before we do a questions for the night is the last 2 really important ECGs to know. And that kind of builds on this hyperkalemia here. Any electrolyte abnormality, even also your STEMIs, can eventually lead to things like this. This here is a normalish, or not normalish, but a heart rate that has, or heart trace that has then turned into what we call ventricular tachycardia here. So ventricular tachycardia is something you definitely don't want. If you get it, you run the risk of it then turning into ventricular fibrillation. So the giveaway that you've got that VTAC is there, those really, really wide waves, so those really, really wide QRS complexes. They tend to be at quite a fast rate, so greater than 100 beats per minute, hence the term tachycardia. And if you see that, you call your reg or consultant straight away, because if you don't, you run the risk of it turning into this, which is your ventricular fibrillation, where the ventricles are literally just flailing around and having a bad time. Both of them need emergency treatment straight away. But you definitely don't want to get to this side. So this is ventricular fibrillation, usually preceded by that ventricular tachycardia that you'll see. And yeah, that is an emergency situation straight away. So there are 2 things that if you see that on the ECG, you press that big red button and you call your consultant or reg over straight away. And that's pretty much everything, guys. I'll leave the QT interval for another time. But the big ones are knowing all those waves and those ST segments and those PR segments. If you have any questions, let me know. And otherwise, I might hand over to Kim to run through the prize questions.
Awesome. Thank you so much, Heather. Yeah, again, if you have questions, feel free to chuck them in the chat and we can quickly discuss them now. But yeah, I think that was a really, really great run through of what is important. And really, if you stick to those single points of how to approach an ECG, then you really won't miss anything. And I think that's a really, really good list that you have there in AMBOSS, really looking at your rhythm first and then going through each section.
Yeah, this is a great resource, guys. And it's great too. Like, I love AMBOSS because you might then see hyperkalemia and you're like, all right. And the consultant goes, well, how do you treat that? And you're like, oh, I remember that girl talking about it on the AMBOSS workshop, but I can't remember. Boom, let's click on it, go there straight away, jump down to treatment, and there we go. We're talking about how you can treat it. So IV calcium gluconate, or you can also give them insulin and glucose. So I know I love AMBOSS for on the ward. I have the question app and also just the standard AMBOSS app, and it has gotten me out of trouble so many times.
Yeah, I absolutely agree. Cool. Yeah, you guys can check it out. I'm pretty sure we send out a 1-week trial code for everyone who does not have access to AMBOSS yet. And we'll also send out a special offer after the last session that we have in August. But now let's quickly go into AMBOSS and run through 3 questions. If any one of you guys needs to leave, of course, feel free to leave. But if you are keen to go through 3 questions that are ECG related, and are keen to win a prize, then it might be worth sticking around for 5 more minutes. So if you can see my AMBOSS now, then as you know, you can go into the QBank and you can create QBank sessions. You can usually filter for all sorts of different things, like different exams, systems, disciplines, whatever you want. But you can also save questions into folders, and then you can go back to that folder if you have a specific exam coming up. And we've selected 3 questions up front, and we'll go through them with you. Then what you can usually do as well in AMBOSS, you can filter for the difficulty. I usually think 1 to 3 hammer questions for preclinical years should be enough. The questions are quite hard sometimes, so don't base your self-esteem on them, I would say. But let's see how we go with these 3 questions now. I will open up the first question now. Heather, you might need to monitor the chat, and when I go to the second question, we might have to quickly write question 2 in the chat so that we can differentiate where the answers are coming from. But let's see how we go. Good luck. I'll make it a little bit larger so that you can hopefully see this well. I'll give you some time to read, and then I'll also show you the ECG. One trick, or what I find always helps, especially with these long clinical question stamps that you have also in med school sometimes, read the last question first, or the last sentence, because often that gives away what you are actually looking for. And then you can go through the stem and filter for the relevant information that you need to answer this question. And that's where AMBOSS is great as well, because we have something called key info, and that sometimes points out the really important things to look out for. So if you just want to quickly do a few questions, I always turn that on, because then I'm quicker at the right information to answer this question.
Arena, we'll chuck the ECG up in a little bit. We'll just give everyone a little bit of time just to read through that, and then we'll put the ECG up so you can see it. It's pretty small at the moment.
Okay, do you think I should show the ECG now?
Yeah.
Okay, so this is the ECG, guys. I'll give you some time to look at it.
Oh, I don't think it's coming through for me, but I think a few people are having issues seeing the actual question.
Okay, interesting. Can you guys see my screen now, and you can see the AMBOSS question?
No, yeah, it's not coming up for anybody. That's really odd.
Okay, that is really weird. Let me try again.
Otherwise, I can just share it off my one too if you want.
Mm-hmm. Can you see it now? Can people see this, or?
One person can. Just see if any others. Yep, a few are saying yes now. That.
Okay, great. Okay,
yeah, awesome.
That works then. Okay. So yeah, again, this green information is the key info button that you can toggle on. I've marked the last question for you, and we'll give you guys some time to read, and then we'll open up the ECG. Okay, I'll open up the ECG. Hopefully you guys can recognize this. Alrighty, and now I'll show you the answers again. We can also give you an attending tip, which gives you a little bit of an additional hint to answer this. It gives you the clinical findings of this patient. So that already rules out a few other things like inflammation, for example. You can then take that answer out. Do we have some answers coming through?
Yep, we've got some C's and some A's. Yep. Yeah, so first one up.
Awesome.
Yeah. So I think first person up that put the correct answer through was Catherine Duddy. And yes.
Perfect. Congrats, Catherine.
So just to quickly let you know, guys, the reason it's not going to be the occlusion of that right coronary artery, and AMBOSS is great. It gives an explanation of everything. But that one you would expect to see leads 2, 3, and AVF with the ST segment elevation. Pericardium, that's something we didn't really cover tonight, but just if anyone's wondering, you tend to see more diffuse, widespread ST segment elevation in that one. It doesn't tend to follow a pattern. And something like your occlusion of the left circumflex artery, you would only really see it in leads 1, AVL 5 and 6 would be a better indication of that. But because we can also see it in those leads V1, 2, 3, and 4, that's why it's probably that proximal left anterior descending artery, because it ends up almost occluding both there.
Awesome. Perfect. Thanks for that great explanation, Heather. And then I would say we go to the second question. So maybe do a quick mark in the chat.
Yeah.
So that we know where we are. And then this is the next question for you guys. Again, maybe start by reading the last question first. So here you're looking for the diagnosis, and then we'll give you some, okay, the only hint here is the ECG. So I'll give you some time to read, and then you can look at the ECG. Okay, so I'll show you what the ECG looks like. And now I'll give you the answers again. Do we have some answers coming through? Or?
Yeah, we got some correct answers coming through, which is awesome to see.
Okay.
So yeah, you guys are spot on. It's going to be D there.
Yeah.
So big giveaway with this one, guys. If Kim, you want to pop that ECG back up again?
Sure.
So unlikely to be myocardial infarction, just because there's no ST segment elevation that we can see there. But the hint is you can see those P waves. That PR segment there, or that PR interval, is getting longer and longer and longer, and then we drop. So you know it's going to be one of those Mobitz ones. And type 1 is your longer drop, and type 2 is that pattern. And a good way to remember that, if you're like, oh, I can't remember which one's which, type 2 has 2 numbers, because remember we represent it as like 2-1 or 3-1 or 3-2. So it's talking about that pattern, whereas type 1 is
that's a good one, yeah. That's a good way to remember that, I guess. Yeah, awesome. Cool.
I think
And who's
Justin Cheng was the winner of that one. First up with correct answer.
perfect? Congratulations, Justin. You also won 3 months of free AMBOSS access. And now last question and last prize code. I'll give you guys some hints again. And we'll quickly show you the ECG. And again, now you have to really think of your approach, what you start looking at when you are interpreting an ECG. All right, and give you the answers again. Do we have some answers coming or not yet?
Yep, we've got some answers come through for that one. So we've got 3 different answers on this one. So SN was the first one with the correct answer. So yeah, it is your atrial fibrillation. And the reason for this is you can see that there's no P waves here whatsoever, and it's irregular. And fun fact too, your paroxysmal AFib is often called holiday heart syndrome because if people go and get on the alcohol a lot, that can trigger this. So that's why I think they mentioned about alcohol consumption in the question. But big giveaway, no P waves, irregular beat. I think one person said Brugada syndrome. That one usually you will see intact P waves in that one. And someone also said sick sinus. And sick sinus, you can have some ECGs that don't show P waves, but you would expect to see, if Kim, you pop up the picture for sick sinus, you actually will see these weird sort of pauses where you're not really getting anything happening there. So we didn't really see any of those on that ECG. So that's why it's AFib.
Awesome. That's a great explanation. Thanks so much, Heather.
Sorry, just quickly, SN, do you want to maybe message Kim on, or if Kim, I don't know if you want to put your email in, because I'm not sure who SN is. You've just got your initials, but if you give us your full name in the chat, or maybe you can email Kim, then we know who it is.
Yeah, your first name would be great, even though I think I already know him. But yeah, all the prize winners, you can send me an email to kke@amboss.com. That's also the email addresses if any one of you has any further questions in regards to AMBOSS in general or anything related to this session. Perfect, Zati. Thank you so much. And then, because we had a few questions coming in, I'll just pop some links in the chat as well. As I said, we have an Enki session coming up. We have a Facebook group where we share all these events, so feel free to join that to stay up to date. And the recording of the first session is linked there as well, and we'll upload the recording of the second session of the cardiac session in the Facebook group. And this session here we'll share with everyone who signed up via email, but then we'll also try to have some live sessions in the future. And yeah, thanks so much for doing this great session, Heather. I think that was absolutely fantastic to have you on board for this. I don't see any further questions coming through, and I think it's probably really late for everyone now, so we'll call it a night.
Yeah. Sorry that went a little over time, guys, but I hope that was a good pace and you're able to keep up with everything rather than rushing it. So hopefully you're ready when your consultant gives you a danger squiggle. You're going to tackle that really well.
I think that was really, really awesome, Heather, with a lot of great explanations. So thanks so much. And yeah, Have an awesome night, everyone. And I would say we see you guys either in our Enki session or next week we have our session on diabetes and complications with Kush from Bond University, who's going to run you guys through that. So make sure you save the date for that and then see you guys soon, hopefully. Thanks so much. Bye.